The first one, it is entitled NCC for Nursing Care of Children, Hematology A and P, and obviously it's just a quick review of anatomy and physiology of the of your blood, basically. So hematology, I don't need to read this to you. It is the study of blood diseases. Hematology and oncology, they usually work together because cancer is a distortion of the blood cells, right? So blood, obviously, it's made up, we have a liquid part of blood, which is our plasma, and then we have our blood cells, which are our red, our white, and our platelet cells, right? The plasma is responsible for carrying a lot of nutrients, also responsible for carrying clotting factors. So you see here, it's 90% water, 10% solutes. Those solutes include albumin, which is a protein, and other proteins that are responsible for maintaining the integrity of our cells, also responsible for tissue repair, things like that. Certain proteins carry other nutrients, they're necessary for carrying those nutrients. Minerals like iron, yada yada. Electrolytes, remember when you're getting your blood drawn and they're looking at your extracellular fluid, that's what they're looking at, the electrolytes in your plasma. They're not looking inside the red blood cells or the white blood cells. The formed elements, so you have the liquid part, which is plasma. The formed elements are your cells. Your red blood cells are responsible for delivering oxygen to the tissues and then removing carbon dioxide from the tissues and delivering it back to the lungs to be expelled, right, through exhalation. The red blood cells are the most abundant. The medical term for red blood cells is erythrocyte. White blood cells are much less abundant than red blood cells. However, they bear a lot of responsibility. If you remember back to week 1, we talked a lot about white blood cells and what they do. They are responsible for immunity and the inflammatory response. And of course, medical term is leukocytes. Platelets. Platelets, the medical term for platelets is thrombocytes. They are created when these megakaryocytes break down. You don't really need to focus on that. But platelets basically are responsible for blood clotting, right? Plasma proteins. So again, those plasma proteins include albumin. Albumin, when we look at a patient's albumin levels, albumin helps maintain the integrity of our cellular membranes and the membranes of the blood vessels. So remember, when the albumin is low, we're going to end up with fluid leaking out of the vasculature into the interstitial space, third spacing, right? Albumin helps keep fluid inside the blood vessels. Low albumin can occur with liver disease. Low albumin is a sign of malnutrition. Fibrinogen is responsible for clot formation. Fibrinogen breaks down into fibrin, and that adheres together to form blood clots. Globulins are proteins responsible for transporting lipids, and also antibodies. Red blood cells. So our erythrocytes are red blood cells. They have a peculiar shape. They are biconcave, so meaning they are like a disc shape with kind of a bowl in the middle. That allows more surface area for the cells to carry oxygen. They do not have a nuclei or mitochondria because of that. To make one, makes more space for oxygen, and for two, it does not require oxygen to keep these cells alive. So they strictly just carry oxygen. Hemoglobin is the protein found on red blood cells that is responsible for the transport of oxygen. Hemoglobin is made up of 4 chains of iron. Low iron leads to low hemoglobin, which leads to low oxygen transport, which leads to low red blood cells. We'll talk about iron deficiency in a minute. All blood cells begin in the bone marrow as stem cells, and then the stem cells split, and some of them become myeloid cells and remain in the bone marrow for maturation, and some of them become lymphoid cells, going to the spleen, the thymus, those lymphoid tissues to develop. And those are your lymphocytes that go to the lymphoid tissue. In the bone marrow, the red blood cells are all developed in the bone marrow. So that's why a bone marrow biopsy helps us to distinguish different blood cancers or anemias. So myeloid means it's in the bone marrow. You don't really need to know all of this, just know, okay, so they go to the bone marrow, they become these little baby cells, then they turn into erythroblasts before they're finally released into circulation. Reticulocytes. Reticulocytes are immature red blood cells. An elevation in reticulocytes could be seen in anemia, also decrease in reticulocytes, certain anemias. Reticulocytes are also increased when there is a high level of destruction of the cells, hemolysis. For example, during a sickle cell crisis, when those cells are sickling, the reticulocyte count is going to be elevated. That is a sign that a patient is in sickle cell crisis, is a high retic count. This shows that the bone marrow is doing its hardest to make more red blood cells in the event of hemolysis, destruction of the red blood cell. The mature red blood cell is your erythrocyte. Red blood cells have a lifespan of 120 days or approximately 4 months. And when they die, they are filtered out with the liver, and the spleen also plays a part in dying blood cells, right? Filtering in them out. If the liver is failing, what chemical is released when red blood cells are destroyed? What chemical is released? Bilirubin. Bilirubin is a byproduct of red blood cell breakdown. Bilirubin. Remember, if the liver is failing and the patient is jaundiced, it's due to a buildup of bilirubin. So patients with anemia will tend to be jaundiced, especially if they have hemolytic anemia. All right, development of red blood cells. I pretty much already said that. The retic count, the reticulocyte are those immature red blood cells, and are a sign of erythropoiesis or red blood cell production. That's what erythropoiesis is. So elevations in retic count are signs of that. Hematopoiesis just means making of blood. Erythro means the red blood cell production, and leuco means white blood cell production. And we already talked about it occurs in the myeloid, which is the bone marrow, and the lymphoid tissue, which is your thymus, your spleen. Those are all lymphoid tissues. All right, we talked about this. This is just telling you about the development of those red blood cells. Again, those old cells are destroyed in the spleen and the liver. So if there is failure of, if there's an issue with one of these organs, then that patient is going to have buildup of bilirubin and they're going to be jaundiced. Or if there's rapid destruction of red blood cells, then they're going to be jaundiced. These minerals and vitamins are essential in the production of red blood cells. So hence, any deficiency in iron, folic acid, or vitamin B12 is going to put the patient at risk for anemia. Platelets, again, they work to form blood clots, right? So low platelets are going to put us at high risk for bleeding, while elevated platelets are going to put us at high risk for clots. Hematocrit. Hematocrit is not a cell. It is a measurement of the percentage of hemoglobin being carried by the red blood, no, the percentage of, yeah, that's right? Percentage of red blood cells, sorry. Percentage of red blood cells in the whole blood. That's what I'm trying to say. So your red blood cells, if your hematocrit is X percent, whatever, 25% or something, I'm just making this up, then that means of your whole blood, 25% of it is red blood cells. I did have it written down what pages in your, let me actually go to this. So on page 256 in your Med-Surg book, there is a table. It gives you the normal ranges for a CBC. Generally speaking, a rough estimate, the rule of threes, red blood cells times 3 should be about equal to your hemoglobin, and hemoglobin times 3 should be about equal to your hematocrit. So again, hematocrit is the percentage of red blood cells in the whole blood. It will be elevated. Remember, if we make extra red blood cells if we have chronic hypoxia. So patients with COPD end up with that polycythemia, extra red blood cells. Also severe dehydration. Remember, dehydration causes hemoconcentration, so our H&H will be elevated with dehydration. And then decreased level would be a sign of anemia. It could also be a sign of fluid overload. I'm sorry, not fluid overload. Yeah, fluid overload, right? The hemodilution. Sorry. Okay. Red blood cells, we already talked about that. The MCV, the mean corpuscular volume, is speaking on the size of the blood cells, and the MCH is the percentage of hemoglobin on the red blood cells. We'll talk about those more in a second. We talked about, again, white blood cells at the beginning of the semester. So this is just a recap on that. Remember the left shift, those bands or neutrophils are immature white blood cells. So like reticulocytes are to erythrocytes, neutrophils and bands are to leukocytes, okay? So remember, elevation in the bands is an indication of an actual infection. Just an elevation in white blood cells alone does not mean that there is an infection. A left shift is more indicative of an infection. There was a question on your exam. in regards to mono, it directed you to the CBC chapter actually. And I think it was just telling you that reduced, a low number of neutrophils could be sign of a viral infection, right? I think that was what it was bringing you to. Don't quote me. I'll have to bring up that chapter again. We're going to do a review in a little bit. I'm going to skip through these questions with ATI because I'm just trying to get through the material, and you guys to be able to have a break, and then we'll do a review. So let's move on. So that was the AMP. That was the AMP. What's it called? Slides, PowerPoint, whatever. Now I'm going to move on to the one that is called ATI anemia. If you are on Moodle, this is the PowerPoint I'm pulling up. Here we go. ATI anemia. All right. So let me share that one. All right. So when we talk about anemia, is it working? All right, here we go. So this is there's 2 slides on anemia in that folder I uploaded. These are in the actual folder for last week because had my son not been sick, we should have been discussing these things last week, although I don't know how that was going to happen with that proctored exam. So what's anemia? Anemia is low red blood cells, right? Neutropenia is low neutrophils. Like leukocytopenia is low white blood cells. Anemia is low red blood cells, okay? And this is going to result in low oxygen carrying capacity. So we're going to have decreased perfusion. So signs of anemia are also going to be signs of hypoxia, could be signs of hypovolemia if it's due to blood loss. Other things that cause anemia could be inadequate production. So if it's hypoproliferation, means cellular production, right? If my bone marrow is not producing enough red blood cells, say, for example, in aplastic anemia, if my bone marrow is not producing enough blood cells, then my reticulocyte count is not going to be elevated, right? Because my blood is not producing enough blood cells to begin with. Versus the hemolytic, that's the destruction of the red blood cells. Remember, that one is going to result in possible jaundice because of that release of bilirubin. Deficiency of vitamins, malabsorption of certain vitamins and minerals, obviously is another cause of anemia. So iron deficiency anemia is by far the most common. Iron deficiency in general is the most common nutritional disorder in the United States, right? Anyone who has chronic blood loss is also going to be at risk for iron deficiencies, such as females with menorrhagia, which is excessive or heavy menstrual flow. Why? Because we need iron to create hemoglobin and carry oxygen in our blood, right? So if we're losing blood faster than we're making it, we're going to use up our stores of iron. So blood loss, chronic blood loss, patients with ulcerative colitis who have chronic blood loss, or any other like chronic bleeding is going to be at risk for iron deficiency anemia. Also, things that put you at high risk for anemia, iron deficiency is growth spurts. So adolescents, infants, and children all are at risk for iron deficiency as well. Malnutrition. introducing babies to cow's milk too early, or keeping them on a milk-only diet forever and not introducing any foods. Both of those can put children at risk for iron deficiency. And then this is just telling you about the folic acid to reduce risk of, sorry, somebody was sending me a message. To reduce risk of neural tube defects, right, like spina bifida. Obviously, meat is going to be our biggest source of iron and other vitamins, basically because we are getting, you know, the iron and vitamins from those animals. So vegetarians are at risk if they're not, you know, balancing their diet well. Vegetarians are at risk for iron deficiency. Remember, red meats are going to be the highest in iron, but they are also not recommended for someone with hyperlipidemia. So they need to eat lean meats like fish, poultry, turkey, chicken, those kind of things. These are your sources of iron in the diet. Also, if you look in your nutritional book or nutrition book, whatever, there is a couple places where iron is discussed. The first one is page 7 in your, or is it 7? Wait, I'm lying. Page 8, sorry, page 8. Page 8 discusses iron there. Gives you some more information on iron supplements. Talks about how iron is absorbed and that kind of stuff. And also there is another chapter in your book that talks specifically about anemia in the nutrition book. Let me pull the page up for you. I apologize. Anemia, where you at? Where you at, anemia? Hold on. All right. There's so much in this. Okay. Page page 73 in the nutrition book discusses sources of iron, B12, and folic acid as well. So page 73 discusses anemia in the nutrition book, as well as page 8, giving you iron, sources of iron. Here's the risk factors for anemia. Again, blood loss, we already talked about that. There is also exposure to certain chemicals, chemotherapy, radiation. They can lead to pancytopenia, reduction in all the blood cells. Obviously, trauma, if you get stabbed, you're going to bleed out, right? Surgery, things like that. All right. Hemolysis. What things put us at risk for destruction of the red blood cells? Sickle cell disease, which we'll talk about in depth in a second. Autoimmune diseases that attack red blood cells or attack the bone marrow. This one, G6PD deficiency, basically that's just an enzyme that protects red blood cells from destruction. You don't really, I mean, the main ones you need to know about is sickle cell. You need to know about iron deficiency, and basically just knowing signs and symptoms of anemia and the major risk factors. I highly doubt you're going to get any questions anywhere along the way about G6PD deficiency, okay? As far as dietary intake, we talked about it, vitamin B12. Vitamin B12 deficiency can come about a few different ways. It can come from just poor intake. If the patient just has a really poor diet, then that can cause vitamin B12 deficiency. Also, pernicious anemia. Pernicious anemia is a deficiency of that intrinsic factor. intrinsic factor is produced in the stomach, and it helps aids in absorption of B12. So some patients, some people are just born that way. And it is the most common cause of vitamin B12 deficiency is pernicious anemia. Malabsorption that occurs in issues such as Crohn's disease, Crohn's disease especially, causes malabsorption in the small intestine, and therefore people are not able to absorb the vitamin B in their GI tract. So because of that, if the vitamin B12 deficiency, unless it's related strictly to poor diet, it must be given either IM or sub-Q, because we're not going to give them oral vitamin B12. That's not going to help them. Even, if they have an issue with absorption, taking a pill isn't going to change their issue with absorption. We have to bypass the GI tract and give them an injection. Folic acid deficiency can also lead to anemia. And again, it can also lead to that, neural tube defects, right? The symptoms are pretty much the same as vitamin B12 deficiency. Now, pica, if you've never heard of it, it is a craving for non-edible items, having a craving of eating things like chalk, eating cornstarch, just wanting to eat weird stuff. That is a sign of iron deficiency, but it's also a cause of mineral and vitamin deficiency as well. So it's double whammy. Bone marrow suppression, again, is another thing that can cause anemia. That's what's occurring with aplastic anemia. Also, chemotherapy causes bone marrow suppression. And that's what this says, aplastic anemia. If the bone marrow is suppressed, remember, all stem cells, everything originates in the bone marrow. So if the bone marrow is suppressed, red blood cells, white blood cells, and platelets are going to be affected. All right. This is just talking about age related factors. So obviously, elderly people are going to be at higher risk for nutritional deficiencies. Anemia can be misdiagnosed as depression. I can say, I told my class yesterday, my grandmother had leukemia, and the leukemia caused issues in the bone marrow. We'll talk about leukemia in a minute. But while she was going through that, she was always tired. She seemed out of it, and she wasn't eating. Her doctor diagnosed her with depression initially. And she kept going back to the doctor. The doctor was telling her everything was fine. She had depression. And as her symptoms got worse, we found out actually she had leukemia. So anemia causes, fatigue and different things like that. So in elderly people, remember, their symptoms of everything can be subtle. They are also at higher risk for GI bleeding. That's why we try not to give them NSAIDs, things like that. So I wanted to pull up the real difference I saw. I mean, it's not much, but between the children's and the adults anemia PowerPoint. Let me move. I can't hide these. Controls are my way. Okay. The only difference I saw was that they just had different manifestations listed, but pretty much the same. So here are your manifestations of anemia, right? They're going to be pale, tired, could be irritable, signs of hypoxia, because our blood count is low, blood is going to tend to go to the most vital organs. So distal points like our fingers and toes are going to have less circulating blood, going to have numbness, tingling, maybe cold, our fingers and toes, shortness of breath due to low oxygen. Again, sickle cell, we'll talk about in a second, that hypoxia can lead to severe pain, sensitivity to cold, and the nail bed deformities. And if you look at the pediatric version of anemia on its manifestations, it's pretty much, a lot of it is the same, but they did give you these spoon-shaped fingernails. That was one of the questions on the proctor, right? So spoon-shaped fingernails could be a sign of anemia. In children, poor development. So they may be smaller than usual. And of course, prone to infection. And in adults or children, a systolic murmur can be heard, okay? So going back to this one, because this is the slides I'm mostly using. Again, labs that you're going to look at, we already discussed this. The red blood cells carry the hemoglobin. Hemoglobin is what transports oxygen. So low red blood cells is going to lead to low oxygen, low perfusion. Remember, perfusion is delivery of oxygen to the tissues. Different types of anemia are going to cause different changes in the cells. Remember that MCV is the size of red blood cells. So iron deficiency anemia is a sign of microcytic anemia. The cells are small, versus vitamin B12 and folic acid anemia result in extra large cells or macrocytic anemia. And there is a table in your book, trying to find the page number for you, that does go over the different types of anemias, the microcytic, macrocytic. The other thing is the oxygen carrying capacity of the lungs, the amount of hemoglobin of the lungs, of the red blood cells. The amount of hemoglobin per red blood cell is expressed in the MCH. So normochromic means they have the normal function of carrying oxygen, versus hypochromic means there's decreased hemoglobin. So in iron deficiency anemia, iron is responsible for the production of hemoglobin. So they are going to have small cells that are decreased in hemoglobin, versus vitamin B12 and folate deficiency is only going to lead to large cells. The cells, you're going to have a lower count of red blood cells themselves, but the red blood cell, each individual cell, still has a normal amount of hemoglobin, if that makes sense to everybody. Now, when we're looking at iron, you have your TIBC, which is your transferrin. It basically, it just tells you the amount of space available and the protein available to bind to iron. So this is the available space, available ability to bind to iron. If we have low counts of iron, then our iron binding capacity is going to be high, because we're going to have extra space available for iron to be transported, and we just have no iron. Ferritin is, as it says right here, showing you the iron stores. And so in iron deficiency anemia, you will see low serum iron and elevated iron binding capacity, right? Hemoglobin electrophoresis. is a diagnostic exam done in the lab. It is used to detect sickle cell and thalassemia. It is the diagnostic test for sickle cell, right? And the Schilling's test, Schilling's test is a test for, it will determine if a patient has vitamin B12 deficiency and whether it's due to pernicious anemia or something else. So that is your Schilling's test. That is the confirmatory test for vitamin B12 deficiency. Bone marrow exam or a bone marrow biopsy is used to diagnose aplastic anemia. It's also used to diagnose leukemia and differentiate leukemia from lymphoma. So obviously patient education is going to be that dietary teaching. I already told you where to find that. Taking their meds as prescribed. We're going to teach them about energy conservation. So anybody that's in an acute anemic state shouldn't be exercising. They need rest. I believe that was a question on your exam as well about sickle cell. A patient in sickle cell crisis does not need, or with sickle cell anemia, they need rest to conserve their oxygen. If you increase the oxygen demands, then they're going to be in trouble, right? Because they already don't have enough red blood cells circulating to transport oxygen. And then just teach them about orthostatic hypotension and dizziness, and then signs and symptoms to report like chest pain, shortness of breath. Medications, iron. Iron is discussed in your med surg book. I forget what page, but it's in there. You'll find it somewhere in the book, right? Oral iron should be taken on an empty stomach. So between meals on an empty stomach is the best way for iron to be absorbed, and vitamin C increases the absorption. Question? Oh, the liquid iron needs to be diluted, right, with juice. That was another question on the exam. IV and IM iron is usually reserved for people with severe anemia. And things you want to tell them to look out for, they may have constipation. They may have a green, dark green appearance of their stool. E-poetin alpha. We talked about this in the renal chapter. The production of red blood cells all starts with the release of erythropoietin from the kidneys. Erythropoietin is a hormone. It stimulates the production of red blood cells. So kidney failure is going to lead to chronic anemia, right? E-poetin is a synthetic.
That's school.
E-poetin is a synthetic man-made erythropoietin. Now, think about this drug. It is a serious drug. It's not prescribed loosely, okay? It's going to increase the production of red blood cells. Therefore, it's going to increase it's going to increase the viscosity or thickness of the blood because you're increasing the solid, remember, elements in the blood. So it's going to increase the thickness or viscosity of the blood. Because of that, you're going to place the patient at risk for high blood pressure, clotting events, heart attack, and stroke. So anytime a patient's being prescribed e-poetin, that is a serious discussion with the doctor. They need to discuss risk versus benefit. Finally, B12, we already talked about that. Remember, it can only be administered orally if it is due to a low dietary intake. But if it has anything to do with pernicious anemia or malabsorption, it must be injected. Folic acid is another medication that can be given to help enhance red blood cell production. And we will talk about blood transfusions in just a minute. Complications of anemia, heart failure. So just like if the lungs are not doing their job providing oxygen to the body, so if I have chronic lung disease, it's going to lead to heart failure, right-sided heart failure in particular. If I have chronic anemia, it's still going to cause the same thing, a decreased circulation of oxygen in my system. So if I don't have enough oxygen circulating, my heart is going to pump harder and faster. If I don't have enough volume circulating, my heart is going to pump harder and faster. So not enough oxygen to deliver to the tissues is going to work my heart harder. Remember, the heart is the one muscle you do not want enlarged. So what can you do? Administer oxygen, administer blood transfusions, the medications as prescribed, blah, blah, blah. We'll talk about that in a minute. And I'm not going through these questions. So this is what I'm thinking for the sake of time. I'm going to run through sickle cell and also hemophilia is quick. And then and hopefully blood transfusions. I should be able to get through all of those because those are all quick by 12:30. Since we already basically didn't start class till 11 o'clock, I'm only going to give you, and you're at home anyway. I imagine half of you are laying in bed or comfortable already. So I'm just going to do a break from 12:30 until 1. And then at 1, we'll come back and either wrap it up real quick and move on to review for the final. And anything else you guys need review on. So let me see here. Everybody good with that? Break at 12:30? Good.
Sounds good.
Because there's no other option. All right, so sickle cell, let's talk about this one. Sickle cell anemia. Now, there is sickle cell disease and there is sickle cell trait. Sickle cell disease is a disease that causes this abnormal, irregularly shaped hemoglobin known as sickle hemoglobin to replace the normal adult hemoglobin. When this occurs, these odd-shaped red blood cells tend to clump together, right? So, and cause vaso-occlusion, puts patients at high risk for clots, cardiovascular events, organ failure, puts them at high risk for infection, all kinds of things. So sickle cell is not a pretty disease. It is a genetic disorder that the patient is born with. It is autosomal recessive, so both parents are carriers of the gene. It primarily affects patients of African descent, not just African Americans, but even those living in Africa. And the next slide tells you about why that is. But the statistic is approximately 1 in 13 African Americans carries the sickle cell gene. Doesn't mean they have the disease, but they carry the trait. that could potentially lead to the disease, right? So, and this here tells you about that. So both parents have the trait or the disease, either one, and that leads to the child having sickle cell disease. Now, sickle cell it's thought that the high incidence of sickle cell is found in areas of the world where malaria is present. The sickle cell is resistant to malaria. So that is why it is primarily affecting certain races of people. Genetic testing is super important when planning to have a baby, right? This is why we test for these genes and do a lot of genetic testing at the beginning of pregnancy to make these predictions. So that sickle cell trait, again, protects patients against malaria. It also, sickle cell trait is not the disease. It will not come with any manifestations. It is just a gene that the patient is carrying. Many patients love to play up their sickle cell trait. Now, sickle cell, when those cells are sickling, that can be triggered by a few things. Usually dehydration. Dehydration can cause sickle cell crisis. Hypoxemia, anything being in a high altitude, patients who have sickle cell and smoke cigarettes, an upper respiratory infection, anything that leads to hypoxia can lead to a sickle cell crisis, and also insult to the body, such as an infection. Infection will also lead to that sickling. When those cells are sickling, does everyone know what I mean by sickle? Anybody not know?
Sickle-shaped red blood cells.
Yep, sickle-shaped. So like instead of that pretty little disc, they turn into these thin, look like thumbnail or a crescent moon or a sickle, like what the Grim Reaper carries. So when those are forming rapidly, they're ineffective at carrying oxygen. They are not properly shaped, so they tend to get clumped up and can cut off blood flow in the blood vessels. So it can lead to a vaso-occlusive crisis, which causes ischemia, right, from the cutoff of the blood flow. Ischemia, no oxygen being delivered to the tissue. So that's going to cause pain, swollen joints, fever, abdominal pain, can even lead to clots, can lead to stroke, can lead to heart attack. Acute sequestration. Sequestration is just blood pooling. So blood pooling, patients with sickle cell tend to have splenomegaly and hepatomegaly. They tend to have jaundice. All that, again, from blood pooling, because we have this clumping or vaso-occlusion occurring, and then in certain areas you're going to have blood pooling. Now there is also destruction of the red blood cells, which can lead to aplastic crisis. Same thing, but now they're going to be at high risk for infection, because remember, aplastic, they're going to have decreased white blood cells. I believe if you were in tutoring the other day, there was a question about what patient to go see first. A child with chest pain, a child with sickle cell, complaining of chest pain, you need to treat them just like an adult at high risk for a heart attack. Children can have strokes and heart attacks because of that vaso-occlusion. So chest pain, shortness of breath in a sickle cell patient should be taken seriously. They can also have a pulmonary embolism or a vaso-occlusion, cutting off blood flow to the lungs. In an acute crisis, it is severe pain, severe pain. These patients require high doses a lot of times of pain medication. They tend, just like cancer patients, they tend to build up a tolerance to opioids because of the severe pain. They've been on pain medications since birth practically, okay? So they are not drug seekers. They are people with severe pain issues, chronic pain issues, and they do tend to have a tolerance. They get a bad rap in the hospital as being drug seeking, and that is not the case. Patients who are dependent on opioids and other pain medications, the medication starts not to work. So they do require higher doses or it wears off faster. That vaso-occlusion, again, it can cause organ damage. It can cause risk for infection, risk for osteomyelitis, and a vascular necrosis. This is a common problem in patients with sickle cell disease, hip avascular necrosis, from a lack of oxygen and blood flow to the hip bone. Some patients with sickle cell end up on dialysis. It can lead to kidney failure. So anything that's going to cut off blood flow, I mean, it can affect any organ in the body. Again, we already talked about the sequestration. That is blood pooling in the organs. So if it's pooling in the organs and not circulating in the blood vessels, that can lead to hypovolemia and hypovolemic shock. Again, the testing for sickle cell, the hemoglobin electrophoresis is your definitive diagnostic test. Remember the reticulocyte count, those are the immature red blood cells. They're going to be produced at a rapid rate in times of when the cells are sickling. And then, I mean, the rest of these, you know, you can do fetal blood cell testing to see, you know, while the baby's in utero, if they're going to have sickle cell at birth. There you can screen, they recommend screening because, like I said, many patients with sickle cell, that is put you at high risk for a CVA, stroke. So Doppler, transcranial Doppler. Doppler is an ultrasound, remember, looking for blood flow. Oxygen, the 3 treatments for sickle cell crisis, they're going to need rest. They're going to need oxygen. They're going to need tons of fluids. You will also treat their symptoms. So they're going to need pain medication, typically narcotic pain medication. If they are anemic, severely anemic, they may require blood transfusions. They may be difficult to type and cross-match for a blood transfusion. Patients who are chronically anemic and end up with chronic transfusions throughout their life end up developing antibodies to other blood. So sometimes it can be difficult to find blood to match patients who've had numerous blood transfusions. If they have an infection, obviously you're going to treat the infection. I believe there was a question on your proctored exam about interventions for the patient with sickle cell. Cold, what does cold do? Cold leads to vasoconstriction, right? If I already have a condition that is going to possibly cut off blood flow, the last thing I need you to do is give me an ice pack and narrow my blood vessels to put me at higher risk. So patients in sickle cell crisis, you can apply heat to their painful swollen joints to cause vasodilation and promote blood flow to the joint. But applying cold is a no-no. You also want to teach them to avoid cold weather. Exposure to extreme cold weather, winter months up north, things like that, can lead to a sickle cell crisis. Overexertion, they need to be mindful of that. If they're exercising too hard, doing too much, anything, hyperthermia, anything, hyperthermia is going to put you in a hypermetabolic state. My body is working harder and faster. Just like overexertion, exercising too much. All of these things increase the body's oxygen consumption. Increased oxygen consumption is going to require my heart to work harder. It's going to decrease perfusion of the tissues. And hypoxia, again, is going to lead to a sickle cell crisis. So if those things hopefully make sense to you, and you need to teach them the importance of immunizations. Anyone with any chronic disease, chronic disorder that puts them at risk for infection. Also, if an infection could lead to serious complications with my underlying condition, immunizations are important. Interprofessional approach, these patients should be referred to hematology or oncology. Remember, hematology and oncology, they work hand in hand together. Treating pain again, and warm packs, like I said, and just alleviating the pain. Antibiotics, analgesics, vaccines, and I believe that is it. Oh, this just tells you about the complications, which we also spoke of. Sickle cell crisis, because of that increased oxygen consumption, and leads to anaerobic metabolism, right? It's going to lead to metabolic acidosis. Any issues with hypoxia, and anaerobic metabolism, which means now my cells have to work without oxygen. Aerobic means with oxygen, requires oxygen. Anaerobic means I'm, functioning without oxygen. Those hypoxia and anaerobic metabolism is going to lead to metabolic acidosis. And then we already talked about the rest of these. Acute chest syndrome, this is just the signs and symptoms. Again, you need to take this very seriously because it could be a sign of ischemia of the myocardium, the heart muscle. In our review, we're going to talk about retractions. I know that was a question it seemed like a lot of people got wrong on the proctored exam. And then regular scheduled visits. They need to get their labs monitored periodically, avoid extreme cold, avoid, anything to prevent infection, smoke cessation, yada, yada, yada. So there goes sickle cell in a nutshell. Hopefully, so far, do you feel like this information is going to help you guys who need to go back and retake, or going to help you with your remediation? Yeah, nay, maybe, hopefully. All right, glad to see everyone's engaged. All right, finally, the last disorder I will talk about briefly is hemophilia. Hemophilia is another genetic disorder that affects children. It's in your PEDS book. It basically is a deficiency in clotting factors and causes a high risk for bleeding. These patients bleed very easily. The most minor trauma can lead to serious bleeding events. There's two different types. You really don't need to know, you don't need to go in depth knowing every little anything about hemophilia, what you need to know is hemophilia is a deficiency in blood clotting factors, and it's going to lead to a high risk for bleeding. So DNA testing is the diagnostic test that's going to confirm diagnosis of hemophilia. Signs and symptoms. So while sickle cell could cause ischemic stroke, hemophilia could cause increased risk for hemorrhagic stroke, bleeding. While sickle cell can cause a decreased perfusion to the joints, hemophilia will cause what's called hemarthrosis, which is bleeding in the joint. So with bleeding in the joint, what do you think? Should I apply hot or cold? Ice or a heat pack?
Cold.
Yes,
Cold.
cold. Ice packs are going to cause vasoconstriction, right? And slow down the bleeding. So in issues with clots and those kind of things, heat is going to help open up the blood vessel and allow more blood to flow, whereas bleeding, we need to apply ice to slow down the bleeding. They may have excessive nosebleeds. They may have like serious bleeding from the most minor, a paper cut may bleed for hours, okay? After getting an injection, they may bleed for incessantly for hours, bleeding gums, all those things. Obviously, you want to look out for signs and symptoms of a hemorrhagic stroke if someone's at risk for bleeding. Avoid injections, venipuncture, anything that's gonna, put them at risk for bleeding. They may need pain meds with the hemarthrosis, but we're gonna avoid NSAIDs, right? NSAIDs are gonna put us at higher risk for bleeding. Again, application of ice, immobilizing, because most of the time what these kids, first of all, it doesn't end up getting diagnosed until kids are usually up, walking around and mobile. And most of the time the manifestations is usually like swollen, painful joints due to that hemarthrosis. So this slide you can read about on your own. Just tells you about education for the patient. And pretty much the things I just told you about. And this goes for anybody who is at risk for bleeding, right? Pharmacology, desmopressin. Remember, desmopressin is a synthetic antidiuretic hormone. So not only does this treat diabetes insipidus, it is also used to treat hemophilia because it increases clotting factors. Here's some other treatments. Again, I highly doubt hemophilia is a rare genetic disorder. I really highly doubt you'll get many questions. You'll see many questions on hemophilia. But the main thing to know is that it seriously increases your risk of bleeding. So just teaching based around that risk for bleeding. Okay. Since it's 12:23, I just want to go ahead and knock out real quick blood transfusions, and then we're going to go on break. And I'll give you a full 30-minute break wherever this break begins from. But I just want to give you this last slideshow, and it should be uploaded into Moodle. Tonight, I'm going to try, now that things have slowed down a little bit, I'm going to try to go back through Moodle and separate the files by category. Also, for those of you who need to remediate, if I didn't post it, I'm going to post it, and actually also helping you study for the final. Again, remember, all this information is from the VADI class, but in my mind, I don't understand the purpose of withholding information from students if we want you to be successful. So I guess technically you shouldn't have any of this information. So yeah, what happens in nursing 2 stays in nursing 2. But I just want to show you there is also, my thing is I want you guys to be successful. It's not like we're cheating, I'm not giving you answers to the tests or anything. Just trying to give you as much available information that there is. I think I already posted it in Moodle. If I did not, here is an already made concept map on sickle cell anemia. Tells you about the signs and symptoms, tells you about client education, nursing interventions. So if it's not uploaded in Moodle right now, I'll upload it on the break. But that will help some of you guys who need to remediate on sickle cell in the from the proctored exam, because I know all these ATI books have very limited information. So finally, the blood transfusion. Now, I did see a good place for you to review blood transfusions and transfusion reactions is on ATI in the My ATI in the Learn tab. You will find the Pharmacology Made Easy 4.0. Inside there is a section on medications. I think it says like hematology medications, and it does say blood products. Very detailed. It shows some videos and everything. So it tells you about administering blood. So basically, if a patient is severely anemic, they may require transfusion of blood. The national guideline is less than 7, a hemoglobin of less than 7 calls for blood transfusion. However, all components of blood can be transfused. So there are platelets. You can get a transfusion of platelets. Fresh frozen plasma. When do you think fresh frozen plasma might be transfused? Anybody know? Fresh frozen plasma contains many clotting factors. So in instances where, say, a patient needs surgery and they need it now, and their INR is elevated, and we don't have time for vitamin K and all that, they may just get a transfusion of fresh frozen plasma. They also call it FFP. Patients with liver disease maybe, and they're at risk for bleeding. Anyone who has their blood is too thin basically and need those clotting factors, that's usually when they'll transfuse fresh frozen plasma. Because thrombocytopenia is not the only reason a person's blood would be too thin. Sometimes they just need clotting factors. Now, if they have thrombocytopenia, low platelet count, then they may need platelets transfused. Albumin is that protein. Remember, it keeps fluid inside the blood vessels. That may be transfused, especially to patients with liver or kidney disease. And then white blood cells to someone who's super neutropenic or something. Whole blood, you're probably never going to see that ever transfused. That would probably be some type of critical emergency that requires immediate volume expansion, and there is nothing else available. I've really never seen anyone receive whole blood. Packed red blood cells is going to be the main one you're going to see being transfused for anemia. Again, the national guideline is hemoglobin less than 7. I would say less than 6. That is really cutting it close. I would go with the national guideline less than 7. But either way, severe anemia. If they have some other reason besides anemia, that their hemoglobin is low, but basically anything with anemia will be a reason why you're getting packed red blood cells. Platelets, I already said, would be for thrombocytopenia, a person with low platelet count. Now the different types of reactions. There are a few different types of transfusion reactions, and your book, you have a whole chapter on this, right? So acute hemolytic is going to be the body is rapidly destroying these red blood cells. And this can occur. What is a condition at birth due to hemolysis? Anyone remember? Because it's similar to what's going on here. So when the blood is incompatible, the RH factors don't match up, your body is going to try to fight off that blood, right? That also occurs, that can occur when mom has a negative RH factor and the baby has a positive RH factor. Remember, it can lead to the mom's cells destroying the baby's red blood cells, which leads to excessive amounts of bilirubin, right, being released. So those babies, that's how babies end up with jaundice, right? Or hyperbilirubinemia. So there's acute hemolytic. Febrile is just that. It's going to come with a fever. Anaphylactic is going to show obviously signs and symptoms of severe allergic reaction. And then there's mild allergic reaction. Circulatory overload, obviously, if I'm transfusing this thick blood, I can put the patient at risk for fluid overload. This is especially, patients at risk for this will be elderly patients, patients with heart failure, who cannot tolerate this, big influx of fluids. Sepsis is another adverse effect. So the acute hemolytic reaction, again, that is when the body is destroying the blood cells. That has to do with RH incompatibility. Sorry, I'm trying to find something in the book. RH incompatibility. Signs and symptoms of hemolytic reaction is going to be low back pain, chills, tachycardia, tachypnea, hypotension. Low back pain is that one that really stands out for hemolytic anemia. The other types of anemia do not cause low back pain. Here we go. Okay. The other thing is febrile reaction. This is actually most common. So remember, when we're transfusing blood, you should be checking the vital signs every 15 minutes and seeing an increase in the temperature greater than 1 degree from the baseline vitals you take prior to is going to be a sign of febrile reaction. So any reaction, no matter what the case may be, you're going to stop the transfusion. If you're infusing a medication, IV, and they have a reaction, stop the transfusion, protect the patient first, observe for signs and symptoms, and then you're going to follow the facility protocol. If they have a fever, you need to treat that with Tylenol. Anaphylactic reactions. Obviously, anaphylaxis is a severe allergic reaction. It leads to systemic vasodilation, so causes throughout the whole body. It's going to cause the blood vessels to open up, which is going to lead to severe hypotension and shock, and ultimately cardiac arrest. Signs of anaphylaxis is going to be, remember, they're going to have tachypnea. They're going to have a feeling of impending doom. They're going to have maybe urticaria, which is hives, all those things. And gosh, I'm trying to find this information for you guys. Okay, I might just have to photocopy it. Anyway, obviously, anaphylaxis is going to be treated just like any other allergic reaction or anaphylaxis. Epinephrine. Epinephrine is a vasoconstrictor, right? It is a vasopressor. It causes the blood vessels to tighten up. So that will take care of the shock and the hypotension. It will help with urticaria, which is hives or swelling. That's why it helps with angioedema. And then obviously steroids or Benadryl. All of these things also will be used to treat anaphylactic shock. So we know the signs and symptoms of anaphylaxis. For your final, you do need to be able to differentiate between the different types of transfusion reaction. Circulatory overload, signs and symptoms of that is the same as any hypervolemia, and crackles in the lungs, shortness of breath, distended neck veins, all that stuff. And then, of course, treatment for that would be diuretics. You can avoid this, especially in elderly patients, by transfusing blood at a slower rate. Monitoring eyes and nose. Same things you'll do for someone with hypervolemia. For patients who are at risk for circulatory overload, often the doctor will order, the order may say transfuse 2 units packed red blood cells, give 40 milligrams of IV Lasix in between units. So they may do that to prevent circulatory overload. And then again, there's sepsis. We know the signs and symptoms of sepsis. If we are suspecting an infection, a blood-borne infection, obviously, because they're getting it straight from the blood, we need to take that bag. After we stop the transfusion, we need to send the bag for analysis for possible culture or whatever. And then we treat it the same as any other sepsis. So that's that. I'm going to email you guys some more resources. Also, because I was able, it's only 12:38, I'm actually going to go ahead and give you an hour. Well, about an hour. We'll say 52 minutes. So we'll meet back at 1:30. At 1:30, we will go over the different cancers, and then we're going to review for the final. Does anybody have any questions before we go to break?
I have a question.
What's up?
After the review for the final, are we gonna break before the mental health?
Oh, yeah. We're gonna have a break. All you're doing in mental health is taking your test, right?
I think so, yes.
Yeah, so I'm Professor Colia right now. So I'm just gonna base it off whatever time we get done, and then we'll get another, break. For those of you that are in mental health, hopefully 2 hours break before it, we don't have to start right at 5:30 or whatever.
Okay, I'm just asking so I could cram.
Oh yeah, you should have time. I also just emailed you a bunch of stuff for mental health. So check your emails. And that's that. Because my other class, they already took the mental health proctor. Did you guys take it or no?
We took it. I think today is the final.
Oh, okay. Well, a lot of the info for the remediation is in that email I sent you also. So yeah, we'll see where time leaves us, and we'll meet back here. Let's say screw it. Let's say 1:40, making it even hour. So I'll see you at 1:40. We'll go over cancer and review for the final.
Carly, can you send
Sounds
the
good,
one
thanks.
over, because I don't see that one in week 14 additional ATI study.
Oh, the blood products? Yeah. Let me I will update that week 14 folder right now.
Okay.
Okay. Anybody else have a question? All right, great. So I'll meet you back here. I'm gonna stop this now so that I can post this video. If I wait till the end of class, it's gonna take forever to download the video. So I'm gonna end the meeting now and we'll just join back in at 1:40. See you then.